Good afternoon, everyone, or good morning, wherever you are. My name is Sonia Hsiung, and I'm the Consulting Director of Tamarack Institute's Collective Impact Idea Area, and it is my pleasure to be hosting today's webinar, Innovative Approaches to Ending Social Isolation in Canada. Today, it is my absolute pleasure to be welcoming to our call today's speakers. After months of social distancing to help prevent the spread of COVID, we're all facing what some are calling a loneliness pandemic. Social isolation is increasingly being recognized in Canada anyway as a public health issue, and today we're thrilled to host this webinar discussion that will explore the state of loneliness and social isolation in Canada, and then also profile some innovative models for fostering community connection, specifically social prescribing and nature prescribing. And I'm thrilled to welcome our panelists for today's webinar. Lisa Richmond is the Vice President of Research from Cardus. She's passionate about rigorous research and finding ways to communicate its value for our society and fellow citizens. Welcome, Lisa. Also on our panel, I'm thrilled to be welcoming Sonia Shong. Sonia is the Project Lead, Policy and Communications at the Alliance for Healthier Communities, and she has experience in a range of sectors spanning from engineering, food security, housing, and healthcare. She brings her diverse sectors together to build healthier communities and promote community connection. And our third panelist today is Dr. Trevor Hancock, a former physician and retired professor at the University of Victoria School of Public Health and Social Policy. He created Healthy Cities 2.0 project that highlights the links between the health of people and the health of the Earth's natural systems, and was also instrumental in initiating the BC Healthy Communities. Welcome to you all. I'd like now to turn our metaphorical baton hand off first to Lisa. In many cases, we know that those of us who are lonely or are facing complex social challenges turn to the healthcare system for support. Primary healthcare providers are often an individual's most trusted relationship with and connection to community. Social prescribing is a simple yet transformative way for supporting patients' health and well-being by responding to their need for social connectedness. Social prescribing is also breaking new ground by building intentional links between health and community service. My apologies here. I was giving you a little bit of background on Sonia. So let me start. My apologies, Lisa. The majority of attention and focus from the media, funders, and organizations tends to be on addressing social isolation among seniors. But in fact, what we know is that we're all at risk for social isolation. And so I'm curious and look forward to welcoming you, Lisa, to share with us some of your latest research on what are we seeing in terms of the issue of social isolation and loneliness in Canada today.
Great. Well, thank you so much for having me on this webinar. I thought it would be good to start first with some definitions of what we're discussing today. So first of all, social isolation. This term is used by researchers and clinicians as a measure of how many connections you have with other people and the frequency of those connections. So those connections might be with your family or others you live with, or friends, people you work with, and so on. It's basically an objective measure. And then loneliness is an emotion, and it refers to your subjective experience of the quality of those connections. So how satisfied you are with those connections. So the first is objective isolation, and the second is subjective or perceived sense of isolation. Now, usually social isolation and loneliness go together, but we could imagine a person who has very few social interactions, let's say a lighthouse keeper who sees people just once a week or just once every couple of weeks when they drive into town to buy their groceries. They would rank high on the social isolation measure, but depending on their emotional makeup, they may or may not feel lonely. And on the other hand, we could imagine a person who is constantly surrounded by all sorts of people every day but who still feels lonely because they don't have someone they feel they can really talk to or who really cares about them. So the two don't necessarily go together always. But these are very serious issues for our society, and I'm so glad that the Tamarack Institute is hosting this event and that you're all here participating in it. I'm sure we'll talk more about the links of social isolation or loneliness, their association with lower levels of physical well-being and mental or psychological well-being. And of course, all of our experience during COVID has created a very timely reason to be talking about this issue as well. So Cardus, the organization, the think tank that I am part of, partnered with the Angus Reid Institute here in Canada, a polling firm, to learn about Canadian social isolation and loneliness. And we did a study in May of 2019, so before the pandemic. And then Angus Reid did a follow-up study in the fall of 2020. So that enables us to see how the pandemic affected Canadians in these areas. So first I'm going to present the findings of the May 2019 survey and then more briefly talk about the fall 2020. And this research is available on the Angus Reid Institute's website and links on the Cardus website, and these URLs can be sent to you after the webinar. So the survey asked various questions to measure how isolated the respondents were, and then these responses were later grouped together to enable the researchers to create what we call the social isolation index. And we placed respondents into one of four categories: very isolated, somewhat not isolated, and not isolated. And we found that the respondents were pretty much spread evenly among those four categories. Very isolated was 29% of respondents. Not isolated, 22%, and the others were about 20-something each. Then the survey also asked questions to measure the loneliness of the respondents and later grouped those together to create a loneliness index, which again had four categories. And here the very lonely amounted to 21% of respondents, and the not lonely 23%, and the rest were distributed in the two middle groups. Then the final step was to bring these two indexes together. And what we found was that 23% of Canadians, so more than 1 in 5, are both isolated and lonely, and they fit into at least one of the very isolated or very lonely groups. Now, the survey also asked about people's certain other characteristics of people, like their income level, their level of education, their ethnicity, and other characteristics. And so we were able to determine that the Canadians in this very lonely and very isolated group had the following characteristics. They are more likely than those in the other groups to be a lower income. 41% have an annual household income of less than 50,000 Canadian dollars. 1/2 of them have a high school education or less. They are evenly distributed by age, so age does not seem to correlate with your measure of isolation or loneliness, which is interesting because we often think of these issues as affecting the elderly, and they do affect the elderly, but they also affect people at all ages. These people were also twice as likely as those in that not lonely and not isolated group to live alone. And according to Statistics Canada, back in 1951, 7% of Canadians lived alone. But in 2016, it was 28%. So that's a big change. Among Canadians over the age of 65, the percent who live alone is 26%. And then finally, the Canadians in this group, Canadians who are visible minorities, which in Canada means ethnic or racial minorities, non-white, Indigenous persons, and LGBT persons are disproportionately represented in this group. And of those three that I just mentioned, the LGBT persons are the most disproportionately represented compared with their representation in the Canadian population as a whole. So at the other end of the scale, we found that 22% of Canadians, again, more than 1 in 5, are not isolated or not lonely. And this group tends to have higher incomes, They are more likely to be married. In fact, 75% of them said that they were married. They're more likely to have children, and just 11% of them live alone. Interestingly, as far as education level is concerned, this group, again, was spread evenly out across the range. So it does not seem like education correlates with, your level of education correlates with isolation or loneliness. I'll just mention a few other findings. One is that young people are overrepresented in the lonely but not isolated group. And in particular, we found that women under the age of 35 were the most likely to fall into this group. So that is something we should try to give thought to why that is and how that might be mitigated. Another finding is that 53% of the people in the lonely but not isolated group report that they live in households with at least 3 other people. So living with others doesn't necessarily make you feel less lonely. Being married or living in a common law relationship, or I'm sure just having a life partner that you live with does correlate with being not lonely. Having a physical disability is highly correlated with social isolation and loneliness. And participating in a faith community is correlated with less isolation. That seems reasonable. Of those who are in the very lonely, very isolated group, 43% said that their mental health was good or very good. And 56% said their physical health was good or very good. If we compare that with those in the not lonely, not isolated, those numbers were 85% and 82%. It's a big difference. So now I'll just briefly talk, I think I have a few minutes left, about the follow-up study. So after the pandemic, it had been in progress for about 6 months. In the fall of 2020, the number, so back in the first survey before the pandemic, the very lonely, very isolated had been 23% of respondents. Now this number had risen to 33%. And of the ones who were not lonely, not isolated, had been 22%, it had fallen to 12%. And this is because there was a great deal of movement on that isolation scale, not necessarily on the loneliness scale, but on the isolation scale. So clearly, those stay-at-home orders and other distancing measures have affected Canadians' isolation from others. When asked about their mental health, the responses were not encouraging, the effect of the pandemic. In 2019, 1/3 of Canadians said their mental health was only fair, poor, or very poor. And now that number is almost half, 47%. And those who lost their job during the pandemic are twice as likely to say that their mental health is poor. And then the final point is it appears from this survey that older Canadians are weathering the pandemic better than younger Canadians are in terms of, again, social isolation and loneliness. The big change in responses has been among the younger cohorts, the responses. So there's other things available in the study, and all the data is online at the website, which will provide you with the URL. And you can read the report in detail, but I'll stop there. That's an overview of the situation today.
I just wanted to thank you so much. I have found in particular that the careful delineation of loneliness and isolation very helpful and useful. And you'll see that the link is in your chat box. And we will have chances to have a dialogue, further dialogue about these, all the presenters, and answer any questions. So please keep putting them into your chat box. And thank you again, Lisa, so much for kicking us off. It's now my privilege to introduce you to Sonia Shong.
Thank you so much for the introduction, Sylvia. I'm so delighted to have this opportunity to connect with all of you. And Lisa has provided an excellent overview of social isolation and loneliness in Canada. And I'm sure many of you are deeply aware that clinical medicine accounts only for around 10 to 20% of a person's health and well-being. The rest comes from a complex mix of factors called social determinants of health that include legacies of colonialism and racism, stigma, access to healthy food, safe housing, sustainable livelihoods, and increasingly we are recognizing the importance of having a sense of connectedness to others. And as you heard from Lisa, there is strong intersections between loneliness and the other social determinants of health. There's a number of studies on the adverse health effects of loneliness, and lonely people tend to be higher users of the healthcare system. And here's just a small sample of all of the recent studies that link social isolation and loneliness to mortality, to frailty, respiratory illness, depression and anxiety, and so on. Conversely, having a strong sense of community belonging leads to a number of positive impacts on health and well-being, on lifestyle choices, on self-management of health. And as we think about supporting communities to recover well from COVID-19, we want to think about how we can intentionally create more interconnected communities that are protective against social isolation and loneliness. And this is where I think social prescribing offers a path forward. Social prescribing, just very simply, is around connecting social services and supports, the social part, with medical and clinical support, which is that prescribing part. And it's a term that comes from the UK, where they have formalized this concept into the delivery of their national health system. And I do want to make a distinction between social connecting and social prescribing. So social connecting is this wonderful thing that happens in healthy communities. It's neighbors helping neighbors, it's caremongering, and so on. Social prescribing is specifically about leveraging healthcare appointments as a doorway to identifying and supporting people to address loneliness and other social determinants of health. So in Ontario, over the last 2 years, the Alliance for Healthier Communities implemented a social prescribing research project in 11 communities across Ontario, which is this map on the left here. And to give you a little bit of context, we are a network of over 100 community-governed, team-based primary healthcare organizations across Ontario that includes community health centers, or CHCs, nurse practitioner-led clinics, Aboriginal health access centers, and community-led family health teams. The organizations are focused on serving people who generally face higher barriers to health for a variety of social and structural reasons, and they deliver a mix of medical, health promotion, and social and community support services. So if you think about a doctor's office nestled within a community center or hub, this is the context in which we implemented social prescribing. So social prescribing looked a bit different in different regions, adapted to their particular resources and contexts, but we were able to distill these 5 core components of what it means to have a structured and supported pathway between primary care and non-medical supports. So the first is recognizing that a patient or a client are individuals with medical needs as well as social needs, yet are also more than the sum of their illnesses. They have interests, they have gifts to give. The second is the prescriber. The primary care or health provider who is able to identify when a patient that they see has underlying needs that can be better addressed non-medically. So research from the UK shows that approximately 20% of the patients consult doctors for problems that are primarily social. So when a socially vulnerable person or marginalized person is experiencing poor health, their relationship with their clinical provider is a significant trusted relationship that they have. It might be the only trusted relationship that they have to a professional, and the advice carries weight. But a healthcare professional is generally not the best suited person to address social needs or to address loneliness. This is where a navigator or a link worker comes in. They can receive the referral from a health professional, they can spend time with the individual to understand their interests and their needs, and support them to connect to other services. And this is about asking what matters to you versus what's the matter with you. And then we have, that's the navigator, who would sometimes support a client and go to programs with them to have that warm handoff. And then we have the social prescriptions themselves that can range from coffee meetups, dancing to support groups. And this is a piece I'll come back to. And so last but not least, the 5th component is data tracking and monitoring. And this piece is so important to understanding and sharing the impact, the feasibility, the cost savings of these kind of non-medical interventions, and to see where the gaps are and to continuously improve. So just on the prescriptions themselves, social prescribing has really enabled us to build deeper integrations and quite innovative partnerships across clinical, social, and ecological sectors. The photo on your left is an indoor walking group that was a partnership between Centretown Community Health Centre in Ottawa and the National Gallery of Canada. So participants walk together to manage their health, they connect socially, and in a beautiful gallery space. The other is a Nordic pole walking group, and that was a partnership with the Seniors Active Living Center, where participants can walk with peer instructors through a local forest trails. The other, let me go back one here. The other piece that is quite important is supporting participants to bring their interest and gifts to co-create and be the solutions themselves. We had a number of amazing programs that evolved out of this type of collaboration. We had Friendly Visiting in Collingwood, we had Soup and Crochet with Grandma Penny in Guelph, and other examples that include dinner meetings, art classes, bereavement groups, and so on. And what we found out was when people are invited and supported to co-create the solution for themselves and others, they report the largest improvements in their feeling of connectedness, in self-confidence, in sense of purpose, in belonging to the community. Just some of the other pieces is that our studies saw very positive results that correspond to a lot of the research that's coming out of the UK and the impacts around social prescribing. So for example, we saw 90% increase in social activities and a 49% decrease in sense of loneliness. And we also saw improvements in the experience of healthcare providers who over the course of the project increasingly found that social prescribing improved their clients' health and well-being and decreased the number of repeat visits. We have a full final report with a lot more details on the research methods and the findings and the stories, which you can read on our website.
Thank you so much. This is fantastic. I know I'm watching, and I'm so glad you've included a link at the bottom, and I'm watching the chat, which you can't see, and there's so many beautiful questions already starting to bubble. So I'm sure we'll have more coming your way. Thank you again so much for this. And now it's my privilege and pleasure to introduce Dr. Trevor Hancock, who wrote on social prescribing in a recent article and describes how in the 1970s, when working as a family physician in a community health center, many of the problems that his patients were facing could not be solved through medical interventions. These were patients that were socially isolated and could have benefited from social prescribing. Dr. Trevor Hancock, over to you.
Thank you very much, Sylvia. And from my part of the world, good morning, everybody. I realize it's not morning for all of you. So let me get straight into this. So as you've already heard, social prescribing is mainly about social connection. It's about making connections for people. And obviously it's something we all need to do. So yes, there are lonely and isolated people who are very lonely and isolated, but there are also people who are somewhat less lonely and isolated. And for a large chunk of the population, social connection is really important. Okay, so I want to frame this a little bit differently, perhaps. This is a slide that's based on a couple of key books that have influenced me. One is James Robertson, way back in 1978, The Sane Alternative. And he talked about finding balance within ourselves, which is sanity, he said, between ourselves and other people, which is humanity, and between humankind and all of nature, which is ecology. That actually, as an acronym, spells out SHE. And then Jeremy Lent, in his book, The Patterning Instinct, talked about the need to reconnect within ourselves and between ourselves and between humankind and all of nature. So when I talk about connection, I'm talking about all three of these things. And so I want to talk about a couple of different ways of approaching in broad terms, social prescribing. And the first, which I came across in Australia a decade or more ago, and some of you may know about, is men's and women's sheds, and then nature prescribing. which is quite broad in its implications. So men's sheds began in Australia in the 1980s and have been followed by what are being referred to there as women's sheds, or sometimes as she sheds. And therefore many of the men that were talked about earlier that are at risk of social isolation, men because they're particularly less likely to talk about their feelings, their problems, their emotions, and how do you find a place for them to do that? And also partly in recognition of what's called the men's health gap, which is something we've tended to ignore. Been a lot of focus on gender inequality with respect to women, but there's actually a very large gender inequality also with respect to men. So it was partly in response to that. So basically, it's a community-based non-profit organization that provides a safe and friendly environment for men to work together in the company of other men. And it's a major objective right from the outset is to advance the well-being and health of the male members. And you'll see a lot of reference to male here for obvious reasons. Men's sheds came to Canada about a decade ago. Doug Mackey founded the first. They were particularly oriented towards older men who'd retired and were sort of hanging around and didn't have a lot of connections or once they'd left work, and a tendency to suffer from isolation, loneliness, and depression. So there are currently about 25 or so of these across the country. Arguably, we could do with more. And then women's sheds, as I touched on earlier, they began somewhat later in Australia in 2015. But really much of the same idea. I liked an article from 2016, which made some really nice links between power tools and empowerment, mental health and metalwork, socialization and sewing, and confidence building. It's really interesting to put these kind of ideas together in the context of women's well-being, women's health. So I think the notion of creating these spaces where people can come together to do things together and can turn into social benefit and community benefit in the process. The second thing I want to talk about is nature prescribing. And I often begin my discussions around connections to nature by asking how many people have houseplants. And generally I find that about 2/3 of my audience will say they have houseplants. And my question is why? Why do we have houseplants? There's something kind of odd in some ways about that. Well, could it be an expression of what E.O. Wilson many years ago called biophilia? He posited that connections, that humans seek connections with the rest of life. We evolved in natural environments, he said, and he believes we have an innate need for nature. I think that is true. And so one of the consequences of that has been this notion of nature prescribing, and that can take many different forms. I remember many years ago working with someone who was working with alcoholics and found that one of the things that worked for them was to give them a plant to look after. They're not accustomed to looking after themselves, never mind other things. Giving them a plant was a way of getting them into thinking about looking after other things and then transferring that to looking after themselves, or a pet perhaps. Nature walks you've heard about already, but there's also gardening, community gardens, birding, all sorts of ways. In Ontario, in BC rather, we have a program called Parks, which is run by the Parks Association. And it's a nature prescription program, a very well formalized, evidence-based nature prescription program, based on the fact that people who spend at least 2 hours in nature each week report significantly better health and well-being. It has all sorts of physical and mental health benefits. And kids who play in green spaces focus better, master motor skills faster, and move more. So many, many benefits. I loved this. The side effects of nature prescribing. Be careful of side effects. You may live longer, have increased energy, reduced stress and anxiety, improved heart health, pain reduction, and better mood. So many good reasons for doing this. But there's an even larger notion to my mind of nature connection. This, of course, is the Milky Way. And this is the big picture of nature connection. The problem, for example, is that 2/3 of the US population and more than half the European population can't see the Milky Way at night because of all the light pollution we have out there. And my question is, if we can't see the stars at night, how do we know our place in the universe? So this is a different scale of connection, but I think it's all part of this sense of having connection to each other, to nature, and ultimately to the universe itself. And then finally, I just want to touch on this. I was, as was Paul Bourne, who heads up the Tamarack Institute, featured in a film called The Great Disconnect, which is getting a lot of airtime right now. It actually won the Best Feature Film Award at the recent Better Cities Film Festival in California. And I was recently involved in a discussion with Tamer Solomon, who is the director, and his partner Sarah, who was the writer on the film, following a showing of the film here in Victoria online. And I threw out the notion that after COVID, we all need to reconnect. So we need to move from the great disconnect that we face to the great reconnect. And a couple of just early thoughts I had about this that you might want to play with. Maybe as soon as we can after COVID, we should have block parties all over Canada as a chance for people to reconnect with each other in their neighborhoods, on their streets and blocks. Maybe we should create human chains to link people together. It's a not uncommon approach. And with that, I will leave it and turn it back to you and to us for discussion. Thank you.
Beautiful, Trevor. Thank you so much. Lots to think about, folks. And now we want to move into the dialogue and Q&A component of our webinar together. There's already been some excellent questions that I've seen folks posting in the chat box. And while we're getting started, so if you have not yet posed a question but have one, please feel free to chime in. There is an early one which I'd like to maybe start with, and that is, it comes at the very beginning, I believe, from, I'm just trying to see if I can find it here. There we go. This one is directed to you, Lisa. If you can start us off. There was a question from Marika about, is the 10% increase in the very lonely, very isolated that you responded to, does it sort of parallel some of those same disproportionate demographics around ethnicity and or some of those subpopulations?
Great question. I don't have the answer to that offhand. The one thing I do remember is that it was in the lower age groups, not in the elderly. But in terms of other characteristics, demographic characteristics, I would have to go back and take a look, unfortunately. But all that data is on the website, and so you can dig into that.
Is there another question on our, Dan? I know you're monitoring in the background the different questions that are popping in. Is there a theme kind of emerging that you'd like to direct some questions toward?
Actually, I've spotted a theme in there, which is around recreation and recreation councillors and advisors and municipal recreation departments. Several people have raised that issue, which I think is a really important one. And of course, I actually often like to reframe recreation as recreation. And we need to think about recreation not simply as going out and playing football or walking in the woods or whatever. It's also about arts and about theatre and about all sorts of ways to recreate yourself and to recreate in general. So I completely agree. I think recreation counsellors programs are incredibly important in this.
Beautiful. Yeah, and it's that reminder of there are these resources that do exist. This is not always necessarily about creating a new role or a new position. It's about linking together those existing networks and positions. Sonia, Lisa, anything you would add to that around the theme of recreation showing up?
No, but I completely agree. Recreation, recreation, I love that.
I have another question coming up here that I could hand off to the panelists. So there has been kind of a theme around the link workers. And so I do have a question here from Nadia, and that's directed towards Sonia. So they're very curious about the social prescribing navigators. And are these people integrated within the community clinics or community organizations? And are they paid workers or volunteers? And any insights on how this role may be compared to peer support workers, common in mental health care teams?
Yeah, thanks, Dan. There are a number of really specific questions outside of the navigators on how the program was actually implemented, which is fantastic to see the interest. I'm sure we will not be able to address all of them. They are all in our final report. It's an 80-page document. You will most likely find the answer to your question in that document. And you can always reach out after. So if you have those really specific process type questions, please take a look. But the navigators, that's a really great question. And tied into the comments around recreation, these are not new roles. To what Sylvia was saying, a lot of social prescribing is around connecting what already exists in a formalized pathway that you can track and follow and speak about impact. And so that is, so the navigators are often existing roles. They are a mix. They are community workers. They are sometimes peer outreach workers. They are settlement workers or nurses, etc. It really depends on the makeup of the community. In our project, because we started off from a health setting, these were all staff within the healthcare setting. In some places, we've used volunteers as part of that co-creation. So some volunteers became these navigators, community connectors. And in some cases, in the UK, I know they've embedded a lot of these in the community. So the navigators are from a community social agency. So it's a very wide range depending on what works and the assets that already exist in the community.
I could just add that my cousin in Sheffield in England, who's retired in her 70s, was a volunteer navigator, and she had no particular training for it, but she was involved in her community, and she loved the job too. It was good for her as well as for the people she was busy connecting.
Yeah, it's fantastic.
So I have an interesting question about, given Lisa's data and the prevalence of isolation and loneliness that transcends ages, and certainly we're seeing present in certain communities more so than others. And I'll maybe direct this question first to Trevor and then invite the other two to chime in. So many of the innovations to address social isolation are really focused on building and or strengthening relationships. And we know that relationships don't scale, right? They're very place-based, they're very community-oriented, and they're person-to-person. So wondered if you had any thoughts or ideas around what's it going to take for us to reconcile this tension between, relationships being very human and one-on-one, and the need for this kind of a connection across an entire nation like ours?
Well, that's an interesting question. I mean, first of all, obviously, as you say, relationships are local. So the notion, if you like, the sort of long-standing environmental slogan of think globally, act locally applies here. I'm not sure we could have a national program, and in any case, given the way we're set up, it needs to be probably provincial, but it does mean that to do this properly, you need some funding, you need some support. It doesn't come free. One of the things it means, I talked a year or two ago about some of these sorts of issues at a medical conference, and I made the point that if 20% of the people who are seen in primary care really have social needs, not medical needs, then their needs are best met through social means, not medical means. And that does mean that the healthcare system is going to have to transfer resources into the social care system. And that's not something that they want to hear. But it's an important message. Unless you're going to find new funding, you have to do better with your existing funding. And we need to be thinking about what is the best way to spend the money we have. And that may well be not on expanding medical care, but expanding some of these sorts of programs. And because you can do it with a lot of volunteers and things like that, you can actually do it much more cost effectively too.
But you need those frameworks maybe and a broader dialogue to get people thinking. Exactly. Because it's really also about shifting norms, isn't it? Norms and how we think about this kind of thing. Yeah, I mean, beautiful.
I think we have to give up this notion that health comes from healthcare. It absolutely doesn't. And I say that as a physician who worked in healthcare and in primary care. But most of health, has already been mentioned, does not come from healthcare. Doctors don't create health. They treat illness. And so if you want to create health, you have to go in a very different direction. And that's maybe another important part of this. We've talked about this as treatment, in a sense, for people who have a disease called loneliness. What we really need is prevention so that people don't become lonely. So it's not that social connection needs to happen only when you find you're lonely. We should be preemptively establishing social connection in every possible way we can so people don't end up feeling lonely in the first place.
Beautiful. Sonia, Lisa, anything you would add to thoughts and ideas around how we begin to scale this kind of thinking and acting?
I read somewhere, and I just was looking and I can't find it, but as part of another study, Canadians were asked, do you know, or how many people do you know that are isolated or probably isolated? And so there was a certain response to that. And then there was another question about, have you personally reached out to an isolated person? And a much lower percentage of Canadians actually had done something in their own life to reach out to somebody that they knew. And I think that's where it starts, right? So I agree with Trevor. There's a role that governments can play, there's a role that organizations can play, and then there's a role that individual people and families and community groups can play. And so if we tended to care better and reach out among the networks that we already have, whether it's someone on your block or whatever, I think we shouldn't forget that all those little efforts can add up to a big impact.
I love that reminder, right? That we all can do something as individuals, and it doesn't have to necessarily always be part of we can't solely rely on formal programs to be the only answer. That's beautiful. Sonia, anything you would add there?
Yeah, I do agree with what Trevor's saying around we need to shift how we integrate the health and social systems and how that funding comes in. And I think the integration is quite important, and reorienting our view of what is medical and what is social. We do have criticisms on the one hand, we have these dual criticisms on the one hand of, that social prescribing is too medical. You're medicalizing people's social. And on the other hand, we have criticism that it's too social. Loneliness is too fluffy to address in the healthcare system. And I think that is the bridge that we need to make. I think individually and collectively, and in all the different work that people are doing, to have those evaluative tools that says that, no, this is the same, we're addressing the same thing here, and that this all contributes to well-being together.
I would just add one other thing. One of the things I think we've learned from COVID is the role of the technology we're using right now, but doing so on a more local scale. So, for example, I have a group of guys that we get together once a month to drink beer and socialize, usually in the pub, which we can't do, then in somebody's backyard, which we can't do, and so we're doing it online. So and it's a very local connection. They're all guys within about 10 blocks of me. And once a month we get together and we do the whole thing online. Similarly for my dance group, I'm a Morris dancer, and I'm actually at 72, I'm the second youngest dancer in the side. They're in their 70s and in their 80s. And we've been dancing together for 20 years. Well, some of them have been dancing together for 40 years. So the being together is really important. And in the midst of pandemic, of course, we're not able to get together and dance, although we did dance all over the summer. But we get together online, at least a few of us do. And in fact, the thing that I'm seeing is that the people who don't have the technology or feel uncomfortable with the technology, they are feeling very lonely. So much so, one of them is moving to the mainland to be with her sister. But those of us who are in on the technology, I think we're feeling much better connected and less lonely. So I think we need, I'm not a big fan of things like Facebook and so on. When some young person says they've got 1,000 friends, but all of them are the other side of the world, they're very isolated, in fact. And so the face-to-face really matters. But this is not a bad, is quite a good alternative when you can't do face-to-face, or for that matter, where your friends and family are on the other side of the ocean. So I think thinking more about the role of technology in social prescription is something we should give some thought to.
Beautiful. And it does then remind me and link full circle back to Lisa's comments about, there are subsets in our community who are particularly vulnerable. And, those of lower income who may not have the means, or those who weren't already tech savvy before, we're going to have to be particularly mindful about if the pandemic continues, what options we have to really help facilitate and make sure that they're not left out of those solutions as well, because I agree with you. We have to find a whole range of different options for folks. Dan, I think we've got time for one more, I'm guessing. Is there another comment or question that you want to kind of wrap things up with for us?
Yeah, I guess there's been kind of a question around how do we sort of scale up the concept of social prescription across Canada. I'm wondering if, Sonia, if you have any insights in towards what are sort of recommendations for groups that want to start and sort of hit the ground running?
I did mention in the chat, we also have a guidebook, so you can also read that. But what I want to say is this, we fall into this trap of, I would want to call it pilotitis. Everyone is starting an innovative program that is, we're all very aligned on the same thing across Canada, but we're not talking to each other. And so it becomes this thing that individual communities have that is a fantastic little program, but it's not a scale, right? Because everyone is funded for their 2-year wonderful little program and has demonstrated great results. And we have a collective interest across the nation and internationally around addressing the issue of loneliness and social isolation. So let's talk to each other and work together and reach out across the different sectors to integrate together. And so I think around a common language, around common goals and frameworks.
On the issue of scaling up, look at the UK where they've established a national academy on social prescribing. It requires something of that scale. It needs, each province needs to set up. I've argued here in BC for a self-care strategy. The missing piece in the entire healthcare system is a comprehensive self-care strategy that runs all the way from self-care through creating healthier communities, through what we're talking about, to self-care at the end of life, preparing for end of life and all the rest of it. Chronic disease self-management is one piece of it, but it's the most care is actually self-care. And it's the missing chunk of the healthcare system. No one has a comprehensive self-care strategy. It's the missing piece we need. And for that, you need to have the kind of institutions such as they've established in the UK, where they have a national academy, I think they call it, for social prescribing.
We are advocating for it. So if there's anyone who knows funders who want to fund something like this, that would be great. But the other piece, I'm sorry, my internet was a little bit unstable, but it's the evaluation. I think everyone is doing fantastic work, but this piece of the non-medical interventions on people's health and well-being is often not tracked. We have lovely qualitative anecdotal stories, but it's not convincing to the system as a whole. And I think building that robust evidence base will help us move in that direction.
This is beautiful. You guys have outlined a number of both, you've made a compelling case for why we all ought to pay attention to this. You've shared some very practical and real examples of what this looks like in action, and what's needed more, I'm hearing, are a way for connecting these pilots together, for sustainable funding beyond the pilot, and for real evaluation data and evidence to demonstrate the impact of this work. What an inspiring afternoon.